Hello, thank you for joining us for today's discussion drive chat, the buzz around diversity, equity, and inclusion from the community-based perspective. My name is Chris Lundy, and I'm a community-based experienced professional born with a rare genetic condition myself, sickle cell anemia. In addition to working in advocacy, I also work in higher education, and I'm excited for today's timely discussion. Today, I have the honor of moderating a discussion drive session with four fellow community-based rare disease experience professionals. Nadia Bodkin, co founder of the Rare Advocacy Movement, Kay-Diene Robinson, rare disease experience expert at the Rare Advocacy Movement, Heather Shorten, founder and executive director of Pompeii Alliance, and Deanna Steinle, rare disease experience expert and emotional intelligence professional at the Rare Advocacy Movement. The real world rare disease landscape is a naturally diverse ecosystem where hundreds of millions of medically complex people navigate complex diagnostic odysseys, an often inept medical system that leaves most having to coordinate their own treatment regimens or that of their loved ones. 95% of rare diseases do not have a treatment option and must instead settle for palliative care in an effort to improve quality of life. The rare disease plight, coupled with the Orphan Drug Act, gave rise to the now thriving rare disease advocacy landscape. Unfortunately, the demographics of the people who engage within the general rare disease advocacy space does not resemble the natural diversity of the real world rare disease community. This is in large part due to socioeconomic disparities that result in exclusion of most of the world's rare disease lived experiences from being represented through the traditional rare disease advocacy platforms. But the rare advocacy movement has put in the work to change rare disease advocacy for the better in becoming the only rare disease advocacy network to deploy meaningful community based diversification programs designed to recognize and value global rare disease voices through the Our Lives Matter Diversity, Equity, and Inclusion Initiative. So, when thinking about diversity and the effort to ensure that resources, opportunities, and community facing messaging are both inclusive and equitable, it is important to be clued in to the language and terminology used to communicate with distinct communities that have been historically disenfranchised. So, because terminology and language play such important roles, I'd like to ask Kay-Diene the first question. Kay-Diene, the language used to describe people who do not classify racially as white have fueled controversy in the United States for centuries. The phrase people of color is used widely as an umbrella term to refer to non white people. However, a different acronym has subtly developed traction, BIPOC, which stands for Black Indigenous People of Color. As a Black woman and an Our Lives Matter DEI professional, how do you feel about the term BIPOC and what it claims to represent?
Well, thank you, Chris, for the question. The first time I heard the term BIPOC as it's pronounced, I was confused because I did not know what it was. So when I did look up what it meant, I felt offended because I am not Indigenous. Yes, I was born in the United States, but I am from Caribbean background. My parents are both Jamaican, so I do not relate to the Black American experience because I was raised Caribbean and I relate more to that. And so being called BIPOC is insulting. And I'm like, don't call me BIPOC. I am not BIPOC. I am not Indigenous. Yes, I'm a person of color, but I am not an Indigenous individual. I understand that it is used widely in academia, but I don't feel, nor do I understand what's wrong with the term Black. I don't consider myself African American. I consider myself to be a Black woman, and I'm okay with being called Black. BIPOC adds on extra unnecessary language and titles that don't describe me, and it also offends those who are actually and truly Indigenous. So it's, to me, it's very disrespectful.
Okay. So I understand that you feel like the term is offensive. However, let's say because you as a Black woman have a certain experience, but there are others who might have the same experiences as you, but may not identify as a Black woman.
Mhm.
How do you feel like the healthcare space or education space or any other spaces should label you or someone else who has multiple similarities when it comes to systemic racism and other systemic issues that plague non-white people?
The term label as a whole, I think that comes in and of itself is from the white masses, and everything has to be labeled. whether it's your gender or your sexual identity, everything requires a label. So even if someone who may have and has a similar experience, I don't have a problem with asking, what would you like to be called? What would you like to be referred to? Because you don't want to assume that just because someone looks one way or another doesn't mean that they are.
All right. Thank you, Ms. Robinson. We appreciate your response. There are other similar terms that are being used, like Latinx and minorities, to describe large groups of non-white communities. Nadia, are you able to speak more to this dynamic as an Our Lives Matter DEI professional?
Yes, thank you, Chris. So Latinx has emerged as an alternative that is used by some news and entertainment outlets, corporations, local government, but mainly universities, to describe the nation's Hispanic population. The intention was to develop a new gender-neutral label, but according to a bilingual US survey conducted in December of 2019 by the Pew Research Center, only 23% of US people who identify as Hispanic or Latin have ever heard of the term Latinx, and only 3% actually claim to embrace the label. So this is quite honestly another example of the academic landscape developing labels from the white perspective without engaging the actual community its efforts claim to serve. Unfortunately, we are seeing the same dynamic in the rare disease advocacy space as well, where the terms BIPOC and Latinx are being used by the academics and embraced by the industry that supports academic, attaching another label to disenfranchised communities who already have embraced identities. And from the community-based side of things, this effort just comes off as detached, pretentious, and an attempt to bundle and generalize statistics about the community's lived experiences for marketing purposes. So as a general rule of thumb, if the term doesn't come from the community, don't use it. The term Hispanic is gender neutral. Latin is also gender neutral. There is no need to develop yet another label to identify Hispanic people. The term Hispanic was actually first used by the US government in the 1970s after Mexican, American, and other Hispanic organizations united and lobbied the federal government to collect data on the population. And the term Hispanic comes from the community. It took like a decade to get the US Census to use the term Hispanic. So each time an academic paper or a marketing campaign publishes the term Latinx or BIPOC, which has its own issues as Kay-Diene described, the community receives the message that the creators of that research initiative or campaign is coming from the white perspective and is not of the community that it's intending to serve. So when it comes to the term minority, that term has actually fallen to the same fate as the term ethnic. Originally, there was absolutely nothing wrong with the terms until the white population turned those terms into derogatory code words, much like the okay hand gesture, which most recently became an official hate symbol for white power. So much like the movie entertainment industry teaching us that the term ethnic is code word that white people use to refer to non-white people being uncivilized. Most recently, the reaction to the 2019 US Census Bureau report that by 2044, the white American population is projected to no longer be the majority in reference to the non-white population, even released a projected majority minority graph, which taught every DEI conscious group that originally embraced the term minority that the dominant white population defines the label as derogatory and negative. White nationalists signified this report as a kind of doomsday clock counting down to the end of racial and cultural dominance, which then triggered a literal race war that led to the January 6th insurrection. So in America, white Americans have utilized its majority status as a marker of dominance. And only until the reaction of the 2019 Census Bureau report, which doesn't even have a real world basis and was actually walked back by the Bureau in March of 2020, the extreme reaction exposed how white Americans really feel about being classified and labeled as a minority. So it is now become an inappropriate and even offensive to refer to any group of color as a minority without referencing which group they are the minority to in the same sentence.
I like that. And I think that, as an academic, I have engaged in the term Latinx. And as we have clearly heard from you, Nadia, that term is not very well received and embraced. What do you think are some things that, as an academic and then someone who's also in the healthcare space, how do we bridge those gaps on using proper terminology to acknowledge the people that we are speaking of? We've talked about Black, Indigenous, people of color, and now we're talking about Latinx. These are still very general umbrella terms, but as Kay-Diene alluded to, if you're speaking about Black people, say Black. If you're speaking of, the Asian community, say that. The Hispanic community, say that. How do we bridge those gaps and bridge those messages across? Because the healthcare space is also an academic space when we think about a lot of our teaching hospitals out there. So how do we continue to bridge those gaps so that proper terminology is used across the board?
It requires communicating with the experts of the community that have been researching and been engaged for years within the community. We've been seeing a lot in the advocacy space, the executives of the space going outside of the community and trying to create experts. And every community has seasoned people inside already that are dedicated to the community. And so finding those people, engaging with those people and listening and respecting those people, that's what's needed. Quite honestly, at this point, every community has stepped up to offer that. It's just now industry needs to take that opportunity to partner.
Agreed. No, I definitely agree on that. So thank you very much. I very much appreciate your response to that and the follow-up. Appreciate your engagement on that.
Thank you.
So much like most industries, we are seeing the rare disease patient advocacy landscape struggling to authentically diversify, with various stakeholder groups struggling to get DEI right from the community-based perspective. Upon further investigation, we have found similar language issues in the advocacy movement. Heather, as the founder and executive director of a rare disease-specific patient advocacy organization, can you speak more to the impact language has on the people of the rare disease community, and perhaps how the advocacy space may be able to do better?
Yes, thank you, Chris. So right now, many organizations and industry stakeholders are rushing to create DEI programs. While this is positive, the most important thing should be to make sure that you're creating a DEI program that's genuine, meaningful, informed, and helpful to the people it's designed to help. Language that is interpreted by a patient to be hostile or insensitive may foster mistrust and anger in doctors and the industry, causing them not to continue to search for a diagnosis. In order for the advocacy space to do better, I believe that the industry must unlearn what they think they know about people of color. As the myths are dispelled, then hopefully the language will change as well. For example, when we talk about people of color as just numbers or percentages, that fosters resentment and ultimately does little to serve the patient. Myths, stereotypes, and biases dictate our language. Ultimately, if you're an organization, community stakeholder, or medical professional that advocates for rare diseases, you must be willing to hear constructive criticism and feedback from disenfranchised people. We have to be able to, and myself included as an executive director, we have to be willing to listen. We have to be willing to ask patients and advocates, how do they want to be addressed? And having more diverse staff so that they learn the languages and not just the dialects and the way people speak in different parts of the country, but also foreign languages. I used to be a social worker in my previous life. And in my time as a social worker, I've also found that the best way to learn about someone is to just ask insightful questions, as well as to actively listen to the answers.
No, I agree. It definitely takes a community for us to be in front of doctors and in front of other senior level healthcare executives to really get our point across in terms of what we need to do and what we need to be provided in the healthcare space. And thank you for what you continue to do. Obviously, this pandemic has changed a lot for us as people of color, particularly emotionally. So Deanna, I want to come to you as an emotional intelligence expert. How do you propose people approach allyship?
Thank you so much. Allyship is truly a two-way street. Industry must want to reach out and have an open, valued discussion with communities, as well as communities must want to advocate and speak with industry at a professional level in setting just like we're doing today. Allyship is a beautiful practice. It's something that should be celebrated. Where we often fall short in allyship is when a person, a patient, or a caregiver are confiding in you about their lived experience. And often we as society, an individual person jumps in trying to compete with their story, and ultimately they're devaluing that moment for that patient or caregiver. It really breaks down that wall of trust that you've probably taken a long time to build that up to begin with. Most people will actually call this moment and say that they're trying to be empathetic. Unfortunately, in that moment, by believing this, that they are empathetic to a certain cause or to a situation or to a purpose, that it stops there. And it's amazing because they think it's a one-stop moment, that they're trying to be empathetic and relate to that person. But believing that, you're not actually fully embracing what emotional intelligence is. And it couldn't be farther from the truth that empathy is the way to emotional intelligence. It's just one word, actually, and it goes on many different levels with emotional intelligence, or EI. And that level can't grow, and it can't even begin to blossom or bloom without the willingness to understand and to grow. And that actually supersedes the entire word of empathy in that situation. My personal experience and what I have come to believe is that when someone is in that situation and telling their story, they've come up with a phrase or a statement that they use in every situation they come across that makes them uncomfortable. And therefore, they're actually practicing something that I call self-glorification practice in empathy, in an empathetic environment. That's not emotional intelligence. That's not even the beginning of where that conversation needs to be left. It's a constant journey. It's a constant way of growth and development within yourself. It's an inward dialogue that has to be had for allyship to begin. With my personal journey in particular, allyship actually did not even begin in the rare disease space, in the rare disease community. It actually began with my early onset. I wasn't even diagnosed. I had a terrible surgery that left me unable to speak and communicate in my first language, which is English. And I actually went and sought out a second language, which was American Sign Language. And I had to engulf myself in that community to truly learn, because I knew no matter what book that I tried to read, that my language was never going to develop properly with the community. It had to be fully immersive. And so by doing that, it led me into a completely different path that I never knew that I was going to be on, and try to become a professional certified interpreter. When having conversations within that community and having those open dialogues and that allyship, we found out there was a need that was not being met, where marketing industries were not talking to deaf professionals and helping them market their degrees, their professional, their business, whatever it is that they are wanting to communicate to the hearing world. No marketing company was asking them, what word choice should I use? Where should I be? Where and what media outlets will actually reach the community that we're trying to communicate to? So years of doing these events and flyers and hours and hours of conversation, I had to humble myself and say, hey, you all did so much for me by helping me through my own pain of speech therapy and learning a second language, and you took me under your wing. We've built this relationship. Now we actually see a need in your community, our community. What can we do? That would have never happened if I didn't go and seek out the community. It's not something I ever would have found in the academic level inside of a classroom. I had to go to the community. And so in that conversation, and that's a whole different story, but with all the events that I did and developing their workshops for the interpreters to get their CEU credits, all that marketing information and that word choice, I always went to them and said, I'm here to speak with you, not for you. And I will never speak on your behalf as a member of the first generation of the deaf community. I am a guest coming into the community. I developed a second language, and you all have embraced me, and I'm truly grateful because they changed my life. But now taking that exact same experience with the deaf community and then applying that into this rare disease space that I'm currently in, all those practices, the conversations, the tough questions, that all applies when we are talking in the medical world, in the healthcare space, in industry and development and research, when we are addressing every community that they're trying to develop treatment plans for. Even as we were preparing today, we had the most amazing, beautiful conversation about how we're in this digital world right now, which is incredible. But the downside to it is society, culture, and language is changing so rapidly. And if we are not communicating with industry and industry isn't communicating with us, and that fluid conversation, those floodgates aren't open, we're going to miss it. And we're not going to be able to fix what can be fixed on a digital platform. I know that print media is a lot harder to change, but from a digital footprint, when we see that there's something that needs to be addressed, it needs to be addressed quickly and efficiently with the input of the community. One day it could be a word that has power and meaning and is a strong word for one community. And then because of a select few, they've taken a word and changed it into something that is offensive and derogatory. And it has taken away that power from the community. I would never have known that if I wasn't talking to the community. That has to be a number one priority for us. And because always language and culture are in flux and constantly changing, we have to be able to be honest with ourselves and say, am I still connected? Am I actively and consciously pursuing that relationship and allyship with those communities?
Thank you, Deanna, number one, for your allyship as it relates to the deaf community. One other thing that I do want to ask you is that once we do talk about our experiences and once we are in these spaces where we are allies for those of us who are not always in these spaces, there's always some talk or some understanding conversation maybe about compensation, fair wages, things like that. How do you see yourself in this space? What conversations are you having in this space? Where can we go from there?
That's a great question. From an event standpoint, I know historically we have been in this terrible pattern of when someone is sharing a lived experience, whether it's a patient, caregiver, or a spouse or a loved one, and speaking on behalf of a rare condition, historically they've not been compensated at fair market value. And I believe the people in this panel, the people that are attending this Congress that we are in today, we recognize that that has to change, that we are all moving forward and we recognize that knowledge. We recognize that the information that we as a community are providing to industry is actually transforming and making new medical developments, new research, new marketing from print to commercial, the treatment protocol, to access programs for everyone. All of those have to be laser focused with the community, which stems from those lived experiences that are being developed because of that allyship, and it should be compensated because it is being the foundation for new developments. And so the biggest takeaway from these amazing panelists that we have today and everything that we've talked about is that we're all here and we have amazing, amazing knowledge behind us. And what makes us different is something to be celebrated, not to divide us. And when we have these allyships and we have these conversations, the lives of the patients, the caregivers, everyone that's involved in these communities that is receiving care and treatment and having those conversations with doctors and nurses is only going to make our lives better and stronger. And moving forward is the only way that this is going to become the new future for us.
Thank you, Deanna. Very much appreciated. We're definitely going to circle back to you. I want to open it up with some general questions to you all. So I'm going to come to you, Nadia. How do you feel about the current trend of diversity, equity, and inclusion, and just how it has just exploded and taken over?
The current DEI trend has been filtered and detached from the community's lived experiences. So many speakers of color have been referencing their personal experience without actually saying what their experience has been. And right now, DEI is being treated like an assumption-based discussion where an expert references disparities, throws a couple stats around, and everyone has to assume the rest. But the current DEI buzz is kind of like a double-edged sword. On one hand, it's great because diversity, equity, and inclusion are on the minds of so many business executives and decision makers. But then on the other hand, so many organizations and companies are getting it wrong. So we are seeing the practice of tokenizing people of color to authenticate programs that have been developed overnight without any input from the experts of disenfranchised communities that have studied DEI extensively and have already developed sustainable solutions. And we are seeing threads of DEI themed PR campaigns that are literally checkbox fly-by-night efforts that have absolutely no meaningful impact on disenfranchised communities. So as a community-based DEI professional, in order to create meaningful DEI strategies and protocol, the industry filters need to be removed and executive decision makers need to start embracing authentic DEI practices if the intention is to truly change things for the better as a humanity-focused society.
I agree. I feel like a lot here lately with the term and the phrase diversity, equity, and inclusion, it's almost kind of been watered down because everybody's using the term diversity, equity, and inclusion. And I feel like there needs to be something that is changed because yes, as people of color, we want the equity and we want the inclusion. We want to be at the table. But I feel like sometimes these tables weren't built for us or designed for us. And sometimes we need to create our own table. But we also need to create our own table for the benefit of making sure that we are still heard and still felt at the healthcare level, at the education level, at the corporate level, any other fields out there that we talk about and that we want to be in and that we see ourselves in. And so one thing, Deanna, that I thought a lot about while you were talking was this upgrade from being an ally to an accomplice. How do you feel about that?
I think the first part, before actions are actually taken, there has to be a huge internal dialogue within yourself. Like I mentioned earlier with empathy, there are times when people will say something truly trying to be empathetic and sympathetic to your situation. When I was at my appointment being diagnosed, I was told straight to my face that in my lifetime, there would not be a cure for me because, in a nutshell, there was not enough drive or monetary incentive to find a cure for my illness. And so at that moment, I felt like I had no ally. I did not even know I had a community to reach out to make me feel like I wasn't alone, that my life truly did matter in a way that wasn't just about the title and label of my illness. And so elevating allyship doesn't have to be on the stage in which we're presenting today. One thing I didn't mention, if you are practicing emotional intelligence to its fullest, at the end of the day, you are totally and unequivocally exhausted because every fiber in your being, every cylinder in your body is constantly absorbing everything around you. The 3-foot circle around you is broken and everything is an outward perspective and you're trying to absorb body language, environment, temperature, location of the situation. Emotional intelligence is just not about becoming a friend. And until you're ready to actually take the actions and to be in the fight to help advocate for yourself, like I had to do, because I felt like I had no one, and to be able to step in and try to either build a bridge in community or to feel like you actually belong in a community. It wasn't up until 3 months ago in my 9 years, I felt like I belonged. So just like you have the levels of empathy, allyship has many levels, and it has to start with yourself.
That's beautiful. And I think it does start with understanding yourself and then going out into the world and saying, now that I understand how to advocate for myself, let me learn how to advocate my fellow people in an actionable way. And I think that is right there, the very definition of what you described in being an accomplice.
When I was talking about the genuine empathy, people can have the greatest of intentions.
Right.
It does not mean that every time something is said or addressed means that it comes from a place of ill intent. It just means that they have never had the hard questions or wanted to reach out to, like, Kay, I love the fact that you just openly say, ask me, just ask me, and have a great conversation. That's something that just needs to be more of the forefront of our thinking instead of led with true assumption.
Yeah, agreed. I want to follow up with that, and I will throw it to Kay-Diene. You said just ask. I think a lot of the times when we ask or people are saying, hey, educate me, they tend to turn into this victim role when they are trying to be educated. So, Kay-Diene, how do you feel like we have to address and approach that?
Great question. In having conversations on previous panels, I have told friends of mine for the first time in my entire existence of living with a incurable condition, I was able to feel empowered because I was not treated as a victim. And I did not get a chance to thank the individual, Deanna, when we had our panel a few weeks ago, and you thanked me for my story. You did not make me feel like I was a victim. You did not make me feel as though sharing my story was brownie points for you to add a notch on your belt to say that I too have an experience similar to that. And you, in sharing people, I've seen people do this and I've experienced people doing this, and where they try to express a similar story with you and try to be relatable, and it becomes about them instead of allowing that individual to share their story and living it at that. And you were the first person in my entire existence, and I'm 31, to ever make me feel like telling my story, how I dealt with it, how I made it and overcame it. You did not make me feel as though you were trying to one up by sharing a similar story. In fact, you just said what you had to say about it and left it at that. To answer your question, Chris, I feel like when people are sharing their stories when it comes to the rare disease space, it can bring tears to your eyes. It can be very emotional, especially if you're comfortable with sharing your story. It can become robotic and almost mechanic because you share it so often. But when you finally experience not feeling like a victim or not feeling like you're trying to one up me by giving your own testimony, therefore discrediting what I had to say, it's empowering in and of itself. So to answer the question fully, in order to truly allow people to not feel as victims is to just simply listen.
Wow. Thank you for that, Kay-Diene. I appreciate
And,
that.
okay, I mean, I remember that conversation, what an impact your story had on me, and I still remember that. But as far as like what I specifically said, I don't remember. But EI and everything that we were talking about, it's not something that can be faked. It's not something that can be forced or written on a sheet of paper and have somebody regurgitate it. In that moment, the conversation you and I had, like I said, still impacts me today. And I did not know that that was the impact it had on you. And having this open conversation, this is life-giving. And it is very, very important. And no matter what my illness does to me, I'm never going to forget tonight.
Thank you, Kay-Diene, and thank you, Deanna, very much for your powerful stories. This is why we are very much doing today's chat. I want to circle back on something that Nadia actually referenced. When it comes to diversity, equity, and inclusion, we feel like a lot of the PR and marketing campaigns have just been checking boxes. And so what I want to ask you is, what do you suggest business executives, marketing strategists, those who come up with the ideas for commercials and different campaigns, what do you suggest they do so that it doesn't look like this commercial or this PR campaign is just checking a box? If these are real live experiences that we have, and this is not just something to put in a 2-minute TV commercial spot?
That's a very good question. And one of the things that we've talked about in detail is making sure it's genuine. Diversity is something that we should be looking at every day in our lives. It shouldn't be work. If you are a community organization, an industry leader, it shouldn't matter the color of a person's skin, their gender, how they identify themselves sexually. Your goal should ultimately be to just provide services to the people because they need it. But also, as Nadia said, it's important to include those communities in the conversation. People in the inner city or a rural community, they're going to need different services than people who live in the suburb. Just as there are a lot of issues for people of color in inner cities and their access to affordable health care or quality care, those are same issues for low-income white people who live in rural communities. So it's important to have those conversations with the people in those communities. and have real conversations. Be prepared to listen. Be prepared to hear feedback that is not positive, feedback that might directly criticize you and your organization. And then be prepared to take that constructive criticism and that feedback and turn it into real services that can help these communities. Because otherwise, there's no point. It's just lip service. And ultimately, those communities will realize it's just lip service. And it's not fair to organizations that are also vying for that grant money who are really trying to do something to help these communities.
Thank you. That was beautifully said. Nadia, you want to follow up?
Heather said it perfectly. She literally laid it out. That's the message right there. That's literally the message.
Yeah.
Is you have to engage the community. You have to be willing to hear negative feedback and not take it personally, and see the insights that they really are and apply them.
Yeah, agreed. Thank you both. Heather, that was a good speech.
Thank you.
I mean, it's more than a speech, right? It's what we need to all see, and it's what we need to all hear, not just, like I said, from a corporate standpoint, but also within ourselves, because we are going to see these things and we're going to have the conversations. We're going to have the uncomfortable conversations.
Definitely.
A lot of people say, it's good, it's bad, it's ugly. It's just real. That's how I like to put it. It's real. I very much appreciate just how you said it and how you laid it all out. That was just absolutely perfect. Thank you for that. We're at the tail end here. I want to, again, thank you all so very much for your experiences, for your time today. I want to conclude with one final question. How do you all feel that education can really bridge the gap when it comes to true actionable service in this diversity, equity, and inclusion space? So, Deanna, I'm going to start with you.
In my personal opinion, if the professionals are already in the hallways, they've missed a huge opportunity. It needs to be something that is integrated way before they ever get that coat or they get onto the floor and they go into rounds and rotations. As Nadia said, we have people in individual communities that are experts that can go in and have these sit-down roundtable discussions in the academic world before they go out into practice. The earlier we have these conversations and we show how it is always developing and get their minds into thinking that it's ever an ongoing conversation. It's not a chapter in a book that you read and you move forward, that they can take those practices and apply them into their own real world profession.
I agree. Thank you very much. Kay-Diene, anything you want to add to that?
That's exactly where it needs to begin. I think it even begins before that. From the moment you decide that medicine or any form of the medical field is where you want to be, it starts in that space of community service and working with these organizations and with the people who you are seeking to serve.
Thank you, Kay-Diene. I appreciate that. Heather?
So I agree that it needs to start in medical school. But I also believe that it's not too late once they get to the hospital. I've had countless times where I've walked into a doctor's office and I've had doctors say to me when I leave, I really learned from you today. And that's empowering in and of itself. Doctors have this vision of what a rare disease patient looks like. So when I walk into the office and they see me, this 5'2" small Black woman sitting on the hospital bed, they're like, you don't look sick. And so that makes for a lot of missed opportunities for rare disease patients to get diagnosed. It makes even more missed opportunities for rare disease patients of color and women to get correctly diagnosed. I went to see a doctor and he told me women don't get muscular dystrophy. Well, Pompe is a form of muscular dystrophy. So education is very much needed. And again, real conversations about what the community needs and what they want, because not everybody in the community is comfortable sharing their story. Not everybody in the community wants to share their story. They just want to get treatment. They just want to be well. And so I think education definitely is at the core of this. But I also feel like we can't have conversations about these kinds of issues without also including insurance. If you are a rare disease patient, you have to be able to have access to quality care and quality insurance. And we know that people of color, people who are low income, are oftentimes underinsured or uninsured.
Agreed. And Nadia, I want you to kind of bring us home, but I also want you to kind of speak to that because we see that a lot of underinsured or uninsured people of color and in our rare disease communities really having a tough time, as we've mentioned already, getting the proper care because of the lack of proper insurance. So how can bridging the healthcare and the education gap, one, and two, how can we continue to advocate on behalf of our communities as it relates to insurance companies?
That actually brings us to what RAM is doing and bringing the community together, bringing professionals like all of us together to provide these community-based insights and educational opportunities, the continuing education side of things, and also the pre-academic side of things where you're not even sure if you're going to be a doctor. There's now opportunities that we're obtaining to teach 8th graders. And that's before you even enter high school and start thinking about college. And it's important to just start unlearning the myths that have been taught to us as children, all of us, and start actually teaching real history, regardless of how hard it is to hear and accept, it's still our history. And if we don't know our history, we're doomed to repeat it. That's where all of these acronyms are coming from, because we don't know our history. We already did the whole white and colored and all these different labels. We've already gone through that. But because we're not addressing our history with especially our youth, we're dooming to repeat it. And so actually bringing our community together, the rare disease space is perfect because it's 320 million strong, right? We are a perfect beta test for the rest of the world. And the same things that affect the rest of the world affect us. The effort that you have to go through to survive this environment has now produced people like us that are professional, but then also have lived experiences and can help now the industry get to that next level. We just need the industry to open up and want to do that now and be authentic. Like Deanna said, start with themselves. To touch on the insurance, that has a lot to do with the advocacy space. Our advocacy side has partnerships with industry, the manufacturers of these medications, of these therapeutics. We need to make sure those patient assistance programs that are developed are actually equitably accessible to people that don't have insurance, that need that financial assistance in order to obtain their medications. And it shouldn't matter where they live in the world. If there's a patient with a rare disease that cannot access a therapeutic that actually exists and can save their life, the entire advocacy environment needs to unite and make sure that that patient gets that medication. We have patient assistance programs that are developed for that already. It's just not accessible yet. And that's because that's what we need to start diversifying our space so that we can bring those programs to the real world rare disease space.
Thank you so much, Nadia, for that. It is imperative that we bring that to these spaces so that people can get the necessary care, the equitable care that allows them to just be seen and be heard and keep going and keep living. So thank you so much, Nadia. Thank you so much, Heather, Kay-Diene. Thank you, Deanna. All of you. Living with a rare disease is not easy. So thank you everyone for sharing all of your powerful stories. I admire and respect all of you so very much. Thank you to the World EPA Congress for having us today. We look forward to seeing you all at the Living Rare After Party and be able to continue conversations from there. And we just thank you all so much for today's chat. Your work does not go unnoticed. Again, my name is Chris Lundy. On behalf of Deanna, on behalf of Kay-Diene, on behalf of Nadia, on behalf of Heather, thank you all so very much for today's chat. And we look forward to having more conversations from here on out. So thank you all very much.